8:30 a.m. in LA and Vancouver, 9:30 a.m. in New York. Good morning to our colleagues in the US and Canada. It's 2:30 p.m. in London, 3:30 in the afternoon in Europe. Good afternoon to our colleagues in Europe. It's 7 p.m. in India, 9:30 p.m. in Singapore, Malaysia. Good evening to our colleagues in Asia. And at 11:30 p.m., it's well past bedtime for our colleagues in Australia. A very warm welcome to all our colleagues. I'm Dr. Anupam Sibal. I'm the president of GAPIO. I work as a pediatric gastroenterologist and I'm the group medical director of the Apollo Hospitals Group. For those who are joining for the first time, the Global Indian Physicians COVID-19 Collaborative was established on 11th April to bring together 1.4 million physicians of Indian origin across the globe on one platform. GAPIO now has members from 49 countries, and this collaborative is a very vibrant, dynamic body that has seen some amazing exchange of knowledge over the last few months. COVID-19, as we know, has been reported from more than 200 countries and territories, 19.5 million cases, and sadly, 724,466 deaths. An explosion of knowledge has taken place like never before. As of today, there are 38,523 publications on PubMed, which works out to 173 papers per day because COVID is only 222 days old. And there are 2,015 papers on COVID published from India. Today, we'll be demystifying lab diagnosis of COVID-19. We have a distinguished group of experts from across the globe. And let's start by inviting Dr. Sudhakar Jonalagadda for his opening remarks. Sudhakar is a dear friend, a distinguished gastroenterologist and a transplant hepatologist. He works in Georgia. Dr. Sudhakar took over as the president of the American Association of Physicians of Indian Origin, API, on 11th of July. Over to you, Sudhakar.
Thank you, Dr. Sibal, and good evening and good morning to US friends. Friends, as you all know, the cry of humanity caused by this pandemic is very sad, dark, and deafening. In this sad, dark, and deafening chaos, allow me to inform, invoke, and invite. Inform you all the situational and RP perspective, invoke the eternal wisdom that has guided the people in distress time and time again. Invite the brilliant expert to share up-to-date information to diagnose the deadly pandemic. We are all trying to practice-based medicine, evidence-based medicine, with these strange diseases, with a lack of clarity because of the quality and quantity of evidence. With the myriad presentation, the lab testing options and prevention strategies and treatment options and supply chaos, chain issues, and pandemic becoming exhausting stress to the medicine and public policy. We, the team of RP, are very confident that the timely action, hope, and medical community.
Sudhir, who of course has the API and the GAPIO hats on, have played a stellar role, and of course, huge amounts of contribution from Canada, from SINS, CAPI, from Australia, IMJA, from BAPIO. So together we are very strong, and thank you so much, Sudhakar. And I'm now going to introduce my dear friend, Dr. Sudhir Parekh. Sudhir Bhai is a pulmonologist and expert in asthma and allergy in New Jersey. He's the chairman and publisher of Parekh Worldwide Media, which is the largest publication and broadcasting house globally for non-resident Indians. And he also owns ITV Gold Channel. Sudhir Bhai is the Secretary General of GAPIO has had multiple awards come his way: the Padma Shri, the Pravasi Bharatiya Samman, the Ellis Island Medal of Honor, and the title of the Knights of Malta. Sudhir Bhai.
Thank you, Anupam. Good morning, good afternoon, good evening, everyone. Welcome to this great GAPIO initiative of COVID webinar. And really, we really brought the knowledge of the COVID to throughout the world, and everyone appreciated a lot. Now, it's my privilege and honor to introduce Dr. Nikhil Bayani. He's a consultant in infectious disease and assistant professor in internal medicine at University of Texas and University of the North Texas Health and Science, USA. Dr. Nikhil is also Chief of Department of the Quality, Patient Safety and Infection Prevention at the Arlington, Texas. Dr. Nikhil has won several awards in last few years. So let's welcome Dr. Nikhil Bayani.
Good morning, good afternoon, and good evening. Thank you very much, Dr. Parikh. On a little side note, I know you very well, Dr. Parikh, because your family members in Salt Lake City are very good friends. Your sister is very good friends with my parents, and we have met nearly 30 years ago at your sister's 25th wedding anniversary party. So yes, it's an honor to be recognized. And once again, good afternoon, good morning, good afternoon, and good evening to distinguished physicians around the world. So here we are. I'm going to be talking about, the COVID-19 testing, and one of the details around this presentation is what we are doing at our institutions here at Texas Health Resource, and of course, the role of the RT-PCR and the nucleic acid amplification testing. So of course, this was a graph I put together early on during the pandemic because there was a lot of concerns from patients, and this is the first time where physicians had to listen to patients. And as we listened to the patients, we cared about our patients, we assured our patients, the patient experience, of course, improved. And one of the ways the patient experience improved is by knowing how we're going to be testing for this emerging disease. So I put this table together, and it's a quick summary here. There are nucleic acid amplification tests, and the primary clinical use, of course, is the diagnosis of the current infection. And the big question comes up here: which specimens are adequate? Are we talking about nasopharyngeal swabs, oropharyngeal swabs, nasal swabs, and nasal or nasopharyngeal washes? Of course, when we order these tests, we always wonder how well they're going to perform. The analytic sensitivity, specificity in ideal settings. The clinical performance depends on the type and quality of the specimen, duration of illness at the time of testing. Initially, we had patients who came to the hospital earlier in the presentation. Clinically, they are acting like COVID patients. However, the tests have been negative. And that became a real frustrating and challenging part. And as I move on the presentation, here at Texas Health Resources, what we have done, we came up with a treatment algorithm which really helped alleviate some of these, false, testing results. And of course, the false negative tests, have resulted from ranges of less than 5% to 40%, depending on the test used. And when I talk about the RT-PCR, the false negative rates definitely go down because the cycle threshold, the number of cycles in the RT-PCR needed to amplify the RNA has actually shown to be far better in terms of false negative rate. So of course, the time to perform these tests range from 15 minutes. The turnaround time, of course, is influenced by the test used and the laboratory workflow. And of course, definitely that includes human power in the lab. The RT-PCR, there are various RT-PCR assays used around the world. The different assays amplify to detect different regions of the SARS-CoV-2 genome. They target 2 or more genes, including the nucleocapsid, envelope, and spike genes, and regions in the first open reading frame, including the RNA-dependent RNA polymerase. Accuracy of these tests have not been systematically evaluated. And like I said, the false negative rates have ranged from less than 5 to 40%. And this was published in the World Health Organization. And this is what we use here as our RT-PCR platform at Texas Health. This is one of them. This is in lab. It's from Abbott. It uses the Alinity platform. It allows us to provide a simple workflow, and it's more efficient, and we increase the testing volume. Because we have a large number of entities within our health system, we needed something a little bit more efficient. So far, the Alinity has been highly efficient. We have a turnaround time of 2 hours. And of course, these tests are available in the United States under the FDA, under the emergency use authorization, and hence the validity of these tests have not been fully proven. The next platform that we do use in our lab, and probably recently in India this has emerged, is cartridge-based nucleic acid amplification testing. Cepheid, the gene expert, of course, has gained fame on identification rifampin resistance and tuberculosis, and the same technology has carried over into the detection of SARS-CoV-2. The test provides rapid detection of the current pandemic. You can have results as soon as 30 minutes with less than a minute of hands-on time to prepare the sample. So really not much is done for preparation. Rather, you have results in 30 minutes. And we have observed that in our clinical setting here, that these results using the Cepheid's Gene Expert system, the results are available in a timely manner. Now, the laboratory-based nucleic acid amplification test is more sensitive than the point-of-care NAT testing, which we also implement in the form of the Abbott's ID Now test. Now, this is an algorithm we have put together for our clinicians. And as you can see in the top left corner, when a person comes into the emergency room, now this is for our inpatients requiring admission. If they come into the hospital, the first test they received is a molecular point-of-care test. As we know, the sensitivity is not as high. Specificity is not as high as the PCR, but it is a sensitive test. So if this is positive, within 15 minutes, we know this person is going to be in our what we call droplet plus appropriate PPEs used, and they would be cohorted to a COVID unit. Now, if the test is negative and the clinician feels that there is an index of suspicion for COVID-19, we assess the clinical risk factors for COVID-19. Of course, if there's no alternative diagnosis, they come from a long-term post-acute care facility like a nursing home or a skilled nursing facility, a rehab facility, memory care unit. Have they had COVID? Have they been exposed to a COVID positive patient, meaning none of them were masked? Could this be a healthcare worker who did not use the appropriate PPE? Then we request for a high sensitivity molecular test in the form of, RT-PCR or even the Cepheid Gene Expert. And if that is, of course, positive, then the patient is treated as a COVID positive patient. But then if it is negative, they are treated as a presumptive COVID negative patient because no test is, definitive. Nothing supersedes clinical judgment. Therefore, our infectious disease consultant would be requested for advice to determine if isolation is needed. And of course, if the test is negative, they're a COVID negative patient. And with every testing, of course, this is a clinical case that came up just 2 days ago that I was seeing this patient with end-stage renal disease, a 44-year-old male with end-stage renal disease on hemodialysis, presented with fever, cough, shortness of breath, and weakness for 3 to 4 days. Now, the patient's daughter tested positive for SARS-CoV-2. The patient the daughter and her boyfriend lived with the patient. Physical examination, vitals were stable. Patient's on 2 to 3 liters of supplemental oxygen. Everything was normal except the lungs. Patient had diffuse crackles at the base. The CT scan of the chest showed your typical COVID-19 imaging, ground glass opacities. The point of care test, the rapid SARS-CoV-2 via NAT was negative. The patient was kept in droplet plus due to the fact patient had high suspicion for COVID-19. Patient was, of course, treated with Decadron, anticoagulation, zinc, and vitamin C. Tocilizumab and remdesivir were not entertained just because the patient was clinically well and was requiring only 2 liters of oxygen. Now, of course, the question comes up, do we further test this patient? And this is a question that was posed to me. And following the algorithm we have, we pursued further testing. We need to determine a diagnosis, of course. The question comes up, do we need to take this patient off isolation if further testing is negative? That way we can preserve our PPE. The patient was tested using the SARS-CoV-2 RT-PCR platform by Abbott, and the result was the SARS-CoV-2 RT-PCR was positive. So what we can take home with this is the patient probably did not have a high viral burden for the rapid testing to pick up the viral particles, even though clinically the patient was behaving like a COVID patient. So take it a step further, we took this to the RT-PCR platform. And of course, what's very important is a cycle threshold. Now, of course, I never got in touch with the lab to find out how many number of cycles were run to amplify the RNA, because in the literature, it's been shown the cycle threshold has not provided much clinical certainty. However, it would be very interesting from a diagnostic standpoint that the number of cycle thresholds helps amplify the RNA virus. So obviously the RT-PCR is the best test that we have at this point, given the fact that we're able to amplify this virus. And that is my presentation. Thank you very much.
Thank you very much, Dr. Nikhil Bhani, and thank you very much, Dr. Sudhir. Now I introduce Dr. Naveen Dang. Dr. Naveen Dang is an alumni of Delhi University, Postgraduate Institute, Chandigarh, and All India Institute of Medical Sciences, New Delhi. He is the recipient of Dr. B.C. Roy National Award for his contribution in the socio-medical field. Dr. Naveen is director of Dang's Lab, New Delhi, which was started in 1985. Dr. Dang is known for his pioneering quality in the field of diagnosis in India. Dr. Dang, may I request you to please introduce the next speaker?
It's indeed my pleasure to introduce today Dr. Ratnamani is a senior consultant, head of microbiology, and in charge of infection control in Apollo Group of Hospitals in Hyderabad. She's a trained mycologist and works along with WHO integrated program in PGI Chandigarh. Along with being a good, competent, and efficient and a well-acknowledged microbiologist, she's also has done an advanced management program from ISB Hyderabad. Dr. Ratnamani is also involved in various quality control programs and is working towards quality improvement and sustenance of quality labs involved in process of improvement of different quality aspects, projects in different parts of the country. Dr. Ratnamani has also the privilege of having written a large number of papers and presentations in national and international levels. Dr. Ratnamani, it's indeed an honor and privilege to introduce you and would request you to speak on antigen testing. Thank you.
Thank you, Dr. Dang. And good evening, good afternoon, and good morning to everyone. I'm going to talk about antigen testing for the diagnosis of COVID-19. So as you know that rapid diagnostic, this for the antigen detects the presence of viral proteins. And the antigens detects are expressed only when the virus is actively multiplying. So this depends on the time of onset of the infection, the concentration of the virus or the load of the virus which is present in the sample, the type of the sample or the quality of the sample collected. And as per the experience of the WHO, it has been seen along with the other influenza viruses, the sensitivity of these tests varies between 34 to 80%. So the antigen detection basically either picks up spike proteins or the nucleoproteins. So the test which is being used in India and which was first approved in India uses the spike proteins. The spike proteins are basically big in size, so they don't have to be amplified and they can be picked up faster. And the sample is nasopharyngeal swab because that is where the virus concentration is maximum. Just briefly about the principle of the testing, it uses artificially produced antibodies against the spike proteins, which are actually incorporated or immobilized on a nitrocellulose membrane. And once the nasopharyngeal swab is collected and there are reagents provided with it and the sample is put on this, it's a card test. So it's put on a card. If the virus is present, it goes and binds and a color band appears. As you can see, I have put two examples. So one is a positive test and one is a negative test. So basically it's a very simple card test. So what are the advantages of antigen testing? As you can see, it's a rapid test. You get a report within 15 to 30 minutes. It is highly specific, so that we know that if it is positive, the rapid antigen test is positive, we are sure that it is 100% positive. Another advantage is that the expertise for performing the test is not required, unlike the RT-PCRs, where a molecular biologist has to be there for performing this test. As it's a simple card test and anyone can be trained, a medical person can be trained to do it. And since it is rapid turnover time, so it can be done in huge numbers, simple tests, so mass testing can be done. And another advantage is that there is no complex equipment which is required. We don't need a special reader, we don't need a special cycler. So it's just a visible interpretation of a test. And the most important thing is decentralization of the testing. So the lab is not burdened. So it's a point of care testing, which will help. You can suppose there are areas in India where complex or a high-end labs are not available. In those places, the approachability to these remote areas can be done, and rapid antigen testing can be done for these cases, and we can definitely identify those who are positive. Well, no, any diagnostic test, none of them are 100% perfect. So each of them have their own limitations. And similar is with the antigen testing. The main important thing is it can be detected only when, as I said, when the virus is multiplying. That is in the early stage of the infection. And since antigen testing doesn't involve amplification, unlike the PCR testing where you are testing the genetic material, which is amplified. So even little amount of the virus genetics is present, RNA is present, it gets multiplied and picked up. So that detects its sensitivity. Whereas in an antigen testing, the viral load makes a lot of difference. If there is a good viral load or a high viral load present, it becomes highly sensitive. Whereas if it is a low viral load or a moderate viral load, the sensitivity might be low. And this leads to a false negative result. That is why its sensitivity compared to the RT-PCR is less. And as I said, the viral load is very, very important. So there is very chance of getting a high false negative. The kits which are being used presently have very high specificity, 100% specificity. So a positive is definitely positive, but the sensitivity varies between 50 to 84%. So these are the limitations with the antigen testing. I know this is a very busy slide, but I have put together the recent other two kits which have also been approved by the ICMR. The first kit was approved was the standard Q. Now subsequently there are two more. One is indigenously made in India and other is from Belgium. And on the right side, you can see the algorithm or the interpretations for these rapid diagnostic tests from FIND. It's a beautiful article. And as you can see, it depends on the prevalence of the infection in the community. In the states where there is a high pretest probability or the prevalence is high, how do you interpret this test? So if it's a true positive, that means you know that 100% sensitivity, it is picked up. A true negative, you know that definitely the patient is not having an infection. A false positive happens when there is a cross reaction with any other virus. Usually none of them cross-react with any of the substances or any other viruses except for SARS, which is actually not present at least in many parts of the country, and not present in many parts of the world. Actually, it only cross-reacts mildly with SARS. And false negative is the one which is the most concerning thing about the antigen testing. So the best strategy for using it, the first thing is that the implementation, I'm sure many of you have seen the advisory from the ICMR. So what I have not put the algorithm here, but ICMR says that you do a testing for an antigen in your emergency areas or in the areas where you are having a high infection rates. And if you get a positive, you know it is 100% positive and you need not do a confirmatory test. If it is a negative and it's a symptomatic patient, then you need to go in for a molecular testing or a RT-PCR testing. If it's a asymptomatic patient, but still if it is in an area where the containment zones, or as I said, suppose in some parts of our country there are high rates, high infections going on, in those areas the follow-up of the patient needs to be done. We might have to take a call whether we put this patient in an isolation and then retest these patients with a PCR or with an antigen testing, because the viral load detects and it actually defines how sensitive this test is going to be. So the strategy for using it is, first is implementing it as per the ICMR, use it for triaging the patients. When the patients come, we know that we have a limited number of beds available for the COVID patients, and we have to have a segregation for non-COVID patients. So when you do it in the triaging and you identify patients who are positive, you can prevent infection from spreading. Second thing is we can immediately prioritize and keep these patients in the isolation units. And those patients whom you are sure that it is negative, those patients go into the normal pool. Any doubt or any symptomatic patients, then we go in for an RT-PCR. And large-scale testings of the patients can be done. So this will help us in isolating these patients and controlling the spread of this in the community. So antigen testings have a good use in areas where the pre-test probability of having the disease or having the infection is high. And these are the references which I have taken. Thank you.
Thank you. Thank you very much, Dr. Ratnamani. Thank you, Dr. Tandon. I think there will be some questions about this, and we'll of course be taking questions in the end. This is a test that has been very useful in India, and Dr. Naveen Dang, who serves on an advisory body, has been instrumental in our journey in terms of testing over the years for the SARS-CoV-2 virus, and I think there's been quite an evolution. So big thank you, Naveen, for joining and for your constant input. We move on to the next session, and it's a privilege to introduce Dr. Pallu Malawala to moderate this session.
Dr. Prashant Patel is working as a consultant in metabolic diseases and chemical pathology at the University Hospitals of Leicester, UK. He is a founding co-director of the National Center for Adherence Testing, which provides testing for 25 hypertension centers in the UK and other countries. Dr. Patel has also authored invited chapters in books, published extensively in leading journals, and supervised PhD students. Dr. Patel is a director of one of the largest CMGs with more than 3,000 staff at university hospitals in Leicester. So he's got very impressive credentials, and we are really looking forward to hear you talk, Dr. Patel.
Thank you.
Right, thank you. Thanks, Dr. Pallu, and thanks, Capio, for inviting me to share our experience of seroprevalence in healthcare workforce for the antibody testing for COVID. These are my declarations. This is where I come from, Leicester, somewhere in the Midlands. This is how it was before. It's changed, obviously, substantially now. And I don't have to remind people that the burden borne by healthcare workers in this humanitarian crisis. I think a lot is known now with regards to what sort of risks in general community and individuals people have, such as ethnicity, being South Asian and being obese, and Afro-Caribbean. It's the increased risk factor for morbidity. We still ought to understand what are the increased risks for in getting the infection itself. And second thing is, how is it prevalent in healthcare workers? So there's urgent need to understand whether seroprevalence differs according to the job roles, ethnicity, doctors versus nurses, specialities, such as ED versus radiology, for example, and the seniority and so on. And this is where we try to kind of unpick the answers. At the time when we did the study, there was not many studies out. I think I'm aware that there's a Spanish data which came out a month ago in Lancet, which was seroprevalence looking at the community, which is around 6%, and there were 500 healthcare workers there, and there was a seroprevalence of 10%, but there was no other further details on it. So this was a prospective observational cohort study looking at the seroprevalence for SARS-CoV-2 IgG in the hospital, acute hospital at University Hospital of Leicester. This is one of the biggest, fourth biggest trust in the country, actually, with the 17,000 employees, and around 38% of them being coming from the BAME background. The antibody testing was largely voluntarily introduced by the government, and it was done between 29th of May to 29th of June. The reason timing is important is it was around 6 to 7 weeks after the UK had a peak epidemic. So it was enough time for people to probably produce antibodies. The only exclusion at the time was people who were actually symptomatic with the disease and people who had the infection confirmed by PCR testing through nasopharyngeal swabbing 3 weeks before. And the reason that they were advised not to have the test was because in our experiments for the IgG antibodies to the nucleocapsid protein, which was a test for with our BUT machine, the sensitivity was around 93.5% at after 3 weeks of infection, and if it was any earlier, it was much lower and thought to be unacceptable. I'm sorry, it's a busy slide, but I think I've highlighted certain things. This is just a basic demographics. You can see this around 10,662 healthcare workers participated in the study, and then out of that, 65% were white population, and 23% were South Asian, and 5% for Afro-Caribbean. And then majority of them, as you can see, are women, which is actually representative of the workforce in the hospital. And as you can see here, there is a wide range of professions, like doctors, nurses, physiotherapists, called as allied health professionals, pharmacists, administrative people, radiographers, healthcare scientists, and cleaners and porters. They were all well represented to make it more meaningful. And also, as a specialty, you can see that they were well represented. There is ED and acute medicine, general medicine, surgery, pediatrics. So the very wide, varied representation. Obviously, with the 17,000 staff, we had a wide, varied representation. So this is the important slide. Really, to make it more concise, I've taken the Ig negative results. I just put positive ones. So overall, as you can see, out of 10,000, more than 10,000 staff who took part, the Ig positivity in the acute trust was around 10.8%. Now, what was interesting was to see that the white people, the positivity was around 9.1%. South Asians was 12.3%, and then Black African is 21.2%. So there's a definitely increased prevalence of this disease, and if you can look at the incidence of the disease in healthcare workers, it's around 11% for women and around 10% for men, and that was statistically significant. Not having a difference was statistically significant. What I meant was in all the healthcare assessments we do, male gender thought to be an important parameter for mortality, but for the infection, as you can see, there's not much difference between the male and female. If you look at the actual occupation, as you can see, the doctors were around 10.3%, and if you can see the horizontal, the prevalence of seropositivity in white doctors was around 8.8%, and the South Asians were 12%, and then the Afro-Caribbean was 16.7%. So, and the nurses, as you can see, is 13.7%, which is much higher than doctors, and I think that's probably to do with the persistent exposure and prolonged exposure. And again, they were actually quite, according to ethnicity as well, they were quite representative as well. As you can see, there's 1 in 4 nearly would have had the disease if you're a Afro-Caribbean nurse. Given that there is increased mortality in certain ethnicities, we have to be mindful that they are when we do certain risk assessments with them. Other representative staff, such as you can see, that administrative and executive, they were a lot lower, 6.8%. Now, the thing I wanted to draw attention was the estate, which is largely the porters, cleaners, staff, around 9.7%. So it's not just a clinical staff who are patient-facing. The other group would also had a high percentage of positivity, so we need to look after them too. This is the part 2 of the same table, looking at the different specialty. As you can see here in general medicine, the positivity was around 17.5%, sorry. And then again, it was representative across the ethnicities as well. And if you're in a surgery, it's around 12%. Pediatrics, it was representing the, probably the COVID workload, 5.8%. Radiology and other non-patient facing, directly patient facing were lower at 7%. What intrigued us was the anesthetics and ICU. as you can see, is quite low at 6.7%. And despite looking after critically unwell patients and exposed to aerosol generating procedures, it was quite low at 6.7%. I don't think we understand why this is a picture. Is it to do with they are quite probably more used to doffing and donning and use of PPEs, or is it used to they were probably having the FFP3 mask straight away? And when this study was done, the actual surgical resistant face mask was not mandatory in UK. So there's another slide which is intriguing. As you can see here, FR1 is equivalent to the first year registrar, first year resident in US or a house officer in other countries. The positivity rate was, as you can see, at around 26%. Again, we really don't understand. Is it to do with they write fresh from the medical school? Is it they don't understand the importance of PPE, or they're not? Is it educational? Is it or is it just that often they are the one who actually go and see the patient first? Is that first port of call? Is it that? Or is it the interaction? So we don't know. The infection is not, obviously infection is probably from the patient, but there is also other sorts of infection from the staph, fomite, and other transmissions. So we don't completely understand it, but nevertheless, it's important that we look after them. Before we deploy doctors into the clinical world from the medical school, we really have to educate them about this. And as you can see, as they grow seniors and they're older, you can see that there was a reducing incidence of the seroprevalence. When they reached the consultant, it was low at 7.7%. There was a similar you can see the similar structure with the nursing staff as well, with the healthcare assistant, the junior most nurses having highest 15.5%, and when they become matrons or a nurse consultant, they were low at around 10%. So probably also reflects some of the responsibilities the senior people take in an administrative job as they go ahead. This is the last but one slide, just summarizing what we have seen there in the form of multivariate adjusted analysis. As you can see here, if you say that a Caucasian has 1, the risk factors for South Asian staff is around 40% more, 1.4, and this was statistically significant. And for Africo-Caribbean, you can see there is nearly 2 to 3 times increased risk work as a incidence of the seroprevalent. And similarly with the occupation, if you say doctors has 1, it's 38% more chance of infection for nurses. And so on. Again, this is a similar picture showing the acute medicine as 1. You can see rest of everybody else is got slightly lower risk of infection. So at the time, this was the largest study on a healthcare worker. I believe there is one more study come up in the Lancet Public Health last week, but that's more of a self-reported app-based study rather than seroprevalence. So it's shown that consistently there's an increased seropositivity compared to general population in healthcare workers too, and it's representing the ethnicity. It is also there is certain demographics of this specialty, job roles, and seniority, which are important when we do the risk assessment. So I think it's just got serious implications for policymakers to design a holistic and individualized occupational risk assessment. And I've just seen a risk assessment from BAPIO, which is much more comprehensive than what we are doing. So these information should probably feed it back to them. This is our team, and I thank you for the kind invitation.
So I was asked to speak on IL6 measurement, and because I'm a clinician, I'm just going to go through reiterate the basics as we go along. Everybody here knows, I'm sure, that it's a glycoprotein, which is not normally secreted by normal cells, but by macrophages, T cells, endothelial cells, and fibroblasts, and has inflammatory and pro-inflammatory activity, and is involved in the production of immunoglobulins, helps in differentiation of B cells, cytotoxic lymphocytes, plasma cells, and modulates hematopoiesis and fibrinogen. And along with IL-1 and other proteins, is found in acute phase of many diseases, including infections, inflammation, rheumatological diseases. So in a nutshell, it's a multifunctional cytokine that regulates the immune response, the acute phase reaction, and hematopoietic system activity. And expression is readily induced by various cytokines, lipopolysaccharides, and viral infection. So what is the relation of IL-6 with COVID is what we are here to discuss. So it has been shown as our evidence over these 222 days has evolved, that the pro-inflammatory cytokines play a pivotal role in pathophysiology of lung damage, because influenza-like illness and SARI have 2 very different outcomes. And it is about the serious acute lung injury that we are worried about. And lots and lots of patients unexplainedly result in fulminant immune reaction, which is mainly sustained by the cytokines. And at autopsy, they've been found to be alveolar infiltration by macrophages and monocytes, and interleukin-6 has been one of the main mediators. And in those presenting with moderate to severe COVID cases, more than about 50% of them have been found to have increased levels. Now, cytokine release syndrome has been talked about a lot, and it is a plethora of release of uncontrolled IL-6, IL-1, 12, 18, TNF-alpha, and interferon gamma, which increases the alveolo-capillary gas exchange, reducing oxygenation in the pulmonary tissue. And here, amongst all of these, the key driver has been found to be interleukin-6 in the hyperinflammatory process, especially in COVID-19. And a meta-analysis initially that was presented by Coombs et al. Found that those presenting with complicated COVID had a 2.9-fold higher amount of IL-6 compared to those who had uncomplicated COVID infection. So why is it important? Because not only pathologically it depicts an inflammatory response, clinically it correlates with respiratory failure. In those patients who have higher IL-6 have been found to be progressing to intubation and mechanical ventilation, and it has direct correlation with mortality. And ARDS in some patients with COVID, despite decreasing viral loads, has been worsening and has been suggested that there's an exaggerated post-immune response, and a lot of these patients have been found to have raised interleukin-6. And the evidence, the largest one that was provided was a meta-analysis of 1,426 patients. All of these were Chinese. And the mean interleukin-6, which is usually, it has various labs have various values, and there's a circadian rhythm of IL-6 values, which can be 1 to 5 in normal circumstances, was found to be 56 picograms per ml in the severe group compared to 17 picograms per ml in the non-severe group. And meta-regression analysis showed that high interleukin-6 levels were related to increased mortality. And this was a scatter plot, which shows there's a direct relation there. And if you forest plot it, you can see that in the severe ones, compared to the non-severe ones, the IL-6 values were much higher, more than 55. And most studies hence took 55 as a cutoff. Now, another study, this was an Italian study of 77 patients from different hospitals that was taken, showed that the area under the curve for IL-6 as a predictive for mortality was quite significant. Also, when risk factors for combined endpoint progression to severe COVID-19 or in-hospital mortality was taken, the logistic regression analysis, apart from other risk factors as age, comorbidity, the CAL score, D-dimer levels, found that IL-6 of more than 25, so this was way lower than 55, had a higher progression to endpoint progression of severe COVID and in-hospital mortality. So the study takeaway here was that it's a good prognosticator of combined endpoint progression to severe disease and inpatient mortality. And this study supported the use of anti-IL-6 drugs to target cytokine storm as a valid therapeutic option with supportive strategies. But when you come down to ground level, there's a lot going on and a lot of talk going on about anti-IL-6 drugs. Very importantly, before we assess or interpret our IL-6 values, few things have to be taken into consideration. The first thing is not every hospital has the ability to do IL-6 levels in-house. So they might have to outsource it. So it's extremely important that it's sent in a plasma vial, which is a yellow top gel vial, and it must be performed within 4 hours, because beyond that, with every hour, the level of IL-6 spuriously increases. Therefore, if a blood sample has been outsourced and if it's not done within 4 hours, the level of IL-6 might be spuriously high. That has to be remembered. And labs definitely must have an honest and clear sample rejection criteria, especially for this test. And normal IL-6 levels, again, I reiterate, do not exclude inflammation, do not exclude cytokine storm. So lots of people depend upon IL-6 as IL-6 values to give anti-IL-6 treatment. But as lots of other evidence has shown, that normal IL-6 values do not exclude inflammation. So if I were to summarize whatever little I've learned about IL-6 in these 200 odd days, that it is a key driver of hyperinflammatory process of COVID-19. meta-analysis has found that there's 2.9-fold higher levels in complicated COVID compared to uncomplicated ones. So one at admission, and if the patient's oxygenation levels and ARDS is worsening, a repeat, if there's a rising trend, then it gives you a chance that anti-IL6, whether you're going to be treating that patient with anti-IL6. Current evidence shows that it's a good prognosticator of progression to severe disease and adverse outcomes. And IL6 inhibitors appear to be efficacious in preliminary investigation, although recent reports like the Covactor trial, etc., have given mixed results to define, what is the value of anti-IL6 like tocilizumab, etc. But serolizumab, etc. studies are ongoing, and I think there is some more time to wait to find out whether routine application of these will be useful. Thank you very much.
Serology, as we know, has played a very pivotal role throughout the diagnosis of diseases where organisms were difficult to culture or not at all discernible, especially in the pre-molecular age era. And we are still foxed by the serological evidences that we get in various infectious diseases, and more so with something like COVID. When, how, which ones, whether it's a combination which is going to work, what is the significance? Is it something like which tells us a reassurance on reinfection and other things? What exactly is the meaning? So all these, I think, would be dealt by Dr. Ram Subramaniam, a great friend, and also it's so good to introduce you once again. Ram has been, he has done his post-graduation from PGI Chandigarh, and he works, as everyone knows, most of you would know, in fact, as a senior consultant in infectious diseases, HIV and tropical medicine at Apollo Chennai. And he got trained in ID and HIV in UK after getting his MRCP, and obtained a diploma in tropical medicine and hygiene from London School of Tropical Medicine. And he is also happens to be an adjunct professor of infectious diseases at Sri Ramchandra Institute of Higher Education and Research, Savita Medical College, Apollo Hospitals Educational Research Foundation, and MGR Medical University, Chennai. Over to you, Ram. So many things to talk about you, but time doesn't permit that way.
Thank you very much, Raman, for those kind words. I have been asked to talk to you about COVID serology. And for any disease, the diagnosis is very important, especially so for any pandemic. This is both to diagnose patients, this is to identify the contacts and check them out, and also to screen at-risk populations and check the effectiveness of the control strategy. So tests are important, but unfortunately, not all tests are scalable and affordable. If you look at the client requirements in most situations, they are way beyond the client budget. So even though the gold standard is the RT-PCR, because of the expense and because of the time involved, we need to look at alternatives to ensure that we can screen our patients better. We need to understand that the serology helps to determine if the individual was ever infected before. In other words, he shows the presence of antibodies. It is not recommended for acute infections because it is detectable only 1 to 3 weeks after the onset of symptoms. Even though antibodies can be detected as early as 5 days, generally it is more reliable beyond 2 weeks. Please understand that this is not used to determine if the individual is immune. So the concept of immunity passports is still questionable. There is no significant advantage in the various assays we check for the specific immunoglobulin class, whether it is IgG, IgM, or total. We still don't know whether it makes any difference at all. It is very important that we choose tests with high sensitivity and specificity. And in the absence of such a situation, you need to do what is called as orthogonal testing, which is a sequence of 2 assays in succession with different methodologies. If one comes positive, the same sample is repeated with another test to ensure that it is truly positive. It is useful for diagnosis of persons presenting late or with complications, typically the multi-system inflammatory syndrome, which is seen in pediatrics, which the child presents after 2 to 3 weeks. it is useful in that situation. We still do not know how long the antibody persists, and we are still not having clarity about the correlation of antibodies and the protection they offer. If you look at the course of the infection and look at the serology or the production of antibodies, you will find that the nasopharyngeal swab, which detects the genetic elements of the virus through PCR, is the earliest one to remain positive, along with the culture of virus in the respiratory tract. This happens even a couple of days before the onset of symptoms. The IgG and the IgM antibodies will start usually after day 5, typically around the 10th or the 11th day, and then the IgM antibodies survive only for a few weeks as of now, the information we have gathered, and the IgG antibodies probably a little longer. If you look at the antibody responses, SARS or the SARS-CoV-2 is a little bit of an outlier in the sense that not typically it is always the IgM which is produced initially. The antibodies are produced against the nucleocapsid protein and the spike antigen. So these are the two antibodies. These two are believed to have neutralization properties. And you look at the occurrence of the antibodies. In some situations, the IgG happens to be produced much earlier than the IgM. This is with regard to both anti-nucleocapsid protein and the anti-spike protein. And the serum antibody levels do not correlate with severity or the protection ability. So even between mild and severe cases, there is no direct correlation between the level of the titer of antibodies produced. In general, the antibodies, as I said earlier, start to be produced about 5 days after the onset of symptoms, and the seroconversion for IgM is around 10 to 13 days. For IgG, it is about 12 to 14 days. The maximum seroconversion happens between 2 to 3 weeks for IgM and 3 to 6 weeks for IgG. The peak again happens somewhere in 4 to 6 weeks time, and probably around the same time for IgG. And as of current studies, the duration of antibody persistence is believed to be 8 weeks for probably both. When you compare this with the SARS coronavirus 1, which was 20 years ago, the antibodies seem to peak in the 3rd month and last for up to a year. But in this, we are still learning about the response of the antibodies. If you look at the testing, the antibodies produced against the spike glycoprotein and the nucleocapsid phosphoprotein are both believed to be neutralizing in their ability. The types of antibody testing is mainly of two, that is, we either detect the binding antibody or the neutralizing antibody. The binding antibody detection is a little easier because it is a test which is done using purified protein antigens from the virus and does not need a high level of biosafety level. So it can be done in BSL-2 laboratories. There are two types amongst the binding antibody detection. The point of care testing, which is something like a pregnancy test, which is done on a card, which is typically using a lateral flow assay, is less sensitive compared to the other test. And the laboratory-based test, which use the ELISA or the chemiluminescence immunoassay, are believed to be, they are all rapid tests. Even the lab tests are pretty rapid, but you need a lab backup. And they are believed to be more sensitive and specific when compared to the lateral flow assay. The lateral flow assay typically uses whole blood, whereas there is a differentiation in the ELISA and the CLIA tests. If you are using tests to detect neutralizing antibodies, that means you need to have a higher biosafety level because you can use either a virus neutralization test where the serum is incubated with cells to detect the plaque reduction, or you can also have a pseudo-virus neutralization test using a pseudo-virus like a variola virus, where you look at the plaque reduction using the neutralization test in this situation. These require a higher level of biosafety. We are also now gathering information that probably the maturity of the antibody also plays a role, and targeting mature antibodies may be beneficial in increasing the testing specificity. So it is believed that the mature antibodies not only recognize the virus better, but also effectively neutralize. So detection of these mature antibodies probably will be more beneficial when compared to the routine screening of antibodies. This test looked at this was a meta-analysis which looked at the various studies currently available using the different methodologies, the ELISA, the lateral flow and the CLIA methodologies. It included 40 studies and over close to 30,000 tests. And it found that the lateral flow assay, the simple point of care test, had the least positive predictive value, about 66% only. The ELISA and the CLIA had a better positive predictive value. And similarly, in patients without COVID also, the negative predictive value was better with the laboratory-based tests. They found that there was a significant difference or a heterogeneity in the various tests, and it would made it difficult to standardize or make it generalize the point of care testing and outpatient population testing in these using these tests. So the selection of tests based on the sensitivity and specificity is very important. This table very clearly illustrates if you have a prevalence of 1 and you use a test which has a sensitivity of 99% and the specificity of 99%, the positive predictive value can be as low as 50%. In other words, 50% of tests which show a positive result may actually be false positive. But as the prevalence increases, when it go to 10% of prevalence, the same sensitivity and the specificity can produce a positive predictive value of as high as 92%. So it is very important to choose the test with a higher sensitivity and a specificity, especially when you have a low prevalence, or as I said earlier, use the orthogonal testing methodology, whereby you repeat the test with another test so that you can get a more specific answer. The different testing strategies include choosing a test with high specificity, focus on persons with a high pre-test probability, typically presenters who come late after symptom onset, or include the orthogonal testing algorithm. It can also be used as a rapid triage for symptomatic individuals, testing contacts of confirmed patients where the pre-test probability would be higher. These serological tests can be used for convalescent plasma screening, especially for trials going on right now. There is some role of these serological tests in travel, and probably more importantly in assessing the herd immunity for community surveillance. They have also been used for workforce screening, but a well-accepted, validated algorithm is still not yet available. What is more important is when a serology is not recommended, it is not to be used in the early part of an acute infection, should be avoided in situations where the prevalence of the infections is low, should not be used for healthcare workers to assess whether they can return to work, what I told you earlier as an immunity passport, should not be used to test patients who are getting discharged from hospitals to see whether they are no longer infectious. We need to understand the limitations because we are still unaware of the kinetics of the antibody response, the longevity of the antibodies and the protection it offers, the specific titer where protection is afforded, and also the correlation between the titer and the nature of protection. There is also some cross-reactivity with other coronaviruses based on some tests which are available. It is believed that the spike protein, the antibodies against the spike protein, are more reliable and less likely to cross-react with other coronaviruses. The methodology and the sensitivity also is quite varied between different tests available. So I leave you with this slide. There's still a lot to learn. There are tall claims coming from various companies regarding testing methodologies, but I think till we have definite validated and approved tests, I think we should still be careful in what tests we use and probably rely more on tests which have stood the scrutiny of time and experimentation. Thank you.
Thank you very much, Ram, and thank you very much, Raman. We move on to the last talk, and then we're going to have a Q&A. It's a pleasure to invite Dr. Rajesh Chawla to moderate the last session. Rajesh is a senior consultant in respiratory critical care medicine at Apollo Hospital, Delhi. He's a past president of the Indian Society of Critical Care and the National College of Test Physicians. He's a former chancellor of the Indian College of Critical Care Medicine. Over to you, Raman, to introduce Dr. Manoj Jain. Rajesh, to introduce Manoj.
Thank you, Anupam. Hi, everyone. We've heard about the tests so far available. So now we are going to hear what will be available and what is in store for us. So I have a great pleasure in introducing Dr. Manoj Jain, who has received his engineering public health degree and doctorate from Boston University. He got trained from the Harvard School of Public Health. Dr. Manoj is an infectious disease consultant and a clinical associate professor at University of Tennessee, Memphis, and Rollins School of Public Health at Emory University of Atlanta. Dr. Jain is an advisor to state government and World Health Organization on COVID-19 and earlier served as a consultant to the World Bank on HIV. Dr. Jain is a writer, a national leader in healthcare quality improvement, and published numerous scientific articles, chapters, and books. So let's see if something new coming up, which is going to be useful in managing these patients. Over to you, Manoj.
Thank you so much, and thank you, everyone. It is indeed humbling and a pleasure to be with this esteemed group of folks. It is unreal what we are going through, and it is actually a credit to GAPIO and API and all of the organizations that you are doing to bring information to the point of care, which are the doctors and over 500 who are with us. So I want to, as the cleanup batter here, someone in baseball that we say who's sort of hitting last, I sort of bring a lot of the diagnoses, the questions, issues that we've come up with and put them together and then see what's coming up next. So some of the key questions when the idea of questioning comes, testing comes up is, are we doing this as a diagnostic test, screening test, or surveillance test? That makes all the world of difference. We also need to ask, as we've heard, is this for a past test or a present test infection that we're looking for? We have to begin to ask of the three types, the PCR, antibody, antigen, and then who to test, the symptomatic, contacts, or asymptomatics. What type of swab to use, what techniques that we can use, which I'll go into in more detail, and the newer techniques that are available. Also, are we administering to this test at the home or in the clinic or workplace? The cost of the test and how good is the test, the sensitivity, specificity, and lastly, will patients accept or not? I'm going to dwell on a couple of these points. We have discussed this in detail today. PCR test, antibody test, and antigen test. The gold standard being the PCR in the US costing over $100 to $150. The antigen test costs about $20 and the antibody is $35, and we know their limitations. One of the critical questions as a public health person that I ask, advising the mayor here and also the governor, is, are we doing these tests for a diagnostic purpose, meaning individual one-on-one? Are we doing it as screening, like we're talking about is in the school setting and universities, which we're thinking of screening in order to open? Or is it a more surveillance type, where we don't provide individual data, but population-based data? Because there's a lot of leniency by the FDA and the CDC on when we do a surveillance test. We just had a call yesterday with the CDC, and they gave us guidance on what you could use as a surveillance test. And I think that those apply to other places as well. And then the broader question, the PCR testing, in terms of looking at it as a symptomatic or a close contact or an asymptomatic. Why does this matter? Is because the positivity rate will be very different in these three populations. So if you're doing large scale testing, you need to know that the symptomatics may be 5 to 10% or more positivity, close contacts maybe 5 to 10%, and the asymptomatics may be less than 1%. I want to make comments on a couple of areas before going into the depths of new tests, because I think all of this matters significantly. What type of a swab are we using? We've heard about the various swabs. Generally, the nasopharyngeal has been the gold standard, but we've been doing the nasal swab, which has a fairly good sensitivity, about 95%. And one of the best is the mid-turbinates, which has had a pretty good sensitivity and specificity, as you see. This is from the IDSA Society recommendations, and would really encourage folks to think more on the nasal swabs, which is something that we've started to do when we're doing asymptomatic testing, which is the mid-turbinate swab for our firefighters, for our children at school. And saliva testing. This is coming up as one of the new tests. One of the companies called Vault Health has a very simple mail-in program, about $150 video monitored, couple of days turnaround time. Now, what are the new and upcoming techniques for testing and different types of tests? One is something called pool testing. What this allows us to do is to expand the number, the volume of tests that one can do. So about 2 months ago, after having learned this technique for TB in India, and I believe many folks in India and China have been doing this, but not as much in US. I went to my mayor and my expert panel and said, let's do a pool testing strategy to go from 1,000 to 10,000 capacity in our city. The New York Times covered our story and in detail, but basically what it means is instead of doing 3 or 5 individual tests, you put them into one. Basically, if you have a low low positivity rate, one of those may come up positive, and then you test those individually. And that saves a lot of individual testing, not having to test all of these samples testing. I would really encourage those who have not started doing this for their pre-ops and for others to talk to their laboratory director and to do that. We're using this to open up our schools and universities. In the US, it does require an FDA emergency use authorizations. Positivity rate has to be low. Otherwise, you don't get the advantage of pool testing that you would. It can be done on a Roche Cobas machine, the Panther Thermo Fisher. And like I said, the capacity expands exponentially, and it makes a huge difference in your lab being able to do a large population. Other newer techniques and tests. A number of point-of-care tests are available. One that we've heard about, the Abbott, the Cepheid, and others. These are PCR-based and have a fairly good sensitivity and specificity. We are using some of them. The White House uses the Abbott. We also use that. You know, there has been controversy as to what the sensitivity is for this test, but generally it's accepted to be fairly high. The NIH is taking a very aggressive approach in encouraging new types of tests. So they have a program called the Rapid Accelerator for Diagnostics, over $1.5 billion to a number of companies. And here are some of the successes, or at least the ones that are taking this support. Ginkgo Labs in Boston, Helix in California, and others in California as well. And they're using this new techniques called next generation sequencing, as well as the CRISPR. Let me take a minute and explain to you what some of those techniques are and what the potential that they hold. What the next generation sequencing does is allows for a high volume of samples to be done through with throughput with DNA sequencing. It employs micro and nanotechnologies. Just over a month ago, one of the companies has been given a FDA approval to do an EUA on it, but not to begin clinical testing. It can do over 3,000 swabs in a run. It is exquisitely sensitive, but it has a turnaround time of over 48 hours, but the cost can be reduced. The present PCR test is about $100. This can go down to less than $20 with a very low number of copies there. High sensitivity and specificity of 98 and 97%. What CRISPR is essentially a way of doing what we call word processing on being a scissors for the DNA. It can be done through a desktop instrument. using either saliva or a swab. Several companies are doing this, has a very high sensitivity specificity, and the cost can be exceedingly low. So these two technologies, keep an eye out. We're going to be seeing something come up. So in summary, we've heard about the basic testing types, the PCR, the antibody, antigen, with the other ones that are coming up. We really have to keep our population in mind. We have to really think about the new techniques. I would encourage you to think about pool testing. There's a great deal of data from Israel and Germany on this. We have taken it up with great success, especially with our low positivity groups such as pre-ops and screening children, and the newer technologies for next-gen and CRISPR. So with that, I want to finish and thank you for the opportunity to talk.
Thank you so much, Manoj, and thank you so much, Rajesh. And we now move on to the Q&A, and we've got two stellar experts to handle that. We've got Dr. Sunitha Reddy, who's American board certified in internal medicine and infectious diseases and a senior consultant in infectious diseases at Apollo Health City, Hyderabad. Expertise includes nosocomial infections in immunocompromised hosts, HIV, multi-drug-resistant tuberculosis. Sai Praveen Harnath is a pulmonologist and critical care specialist, senior consultant at Apollo Health City, Hyderabad. He's American board certified in internal medicine, pulmonary medicine, critical care. He's also the medical director of the Apollo E-Access Tele ICU services. So over to Sunitha and Sai.
Exceptional participation by the people who are attending, all 430 of you asking great questions. I'm actually going to start right at the bottom. One of the most recent questions was a very practical one. We've talked about all kinds of tests. A dentist is asking, what do I need to do to restart my practice? What test do I pick up? So I'm going to the panel and request Dr. Ram and Dr. Sushmita to kind of weigh in very briefly on what would be a practical way to pick a test to say, how do we go forward? And then we'll get into the details of each test.
Okay, I'll take this first. Actually, there is no specific screening for going back to practice. I know there are a lot of physicians and surgeons, and several of them senior physicians over the age of 60, who are concerned about the risk they may suffer when going back to practice, but there is no foolproof test. The only advice I give anyone is consider every patient as COVID positive. So routinely screening all patients is not of any use. The surgeons screen all elective cases to see whether the person could be asymptomatic and positive, more to determine the prognosis of the surgical outcomes rather than for infection control purposes. The approach would be to treat everybody as positive and take appropriate precautions. At least a basic minimum is necessary.
So no, I completely agree with Ram. I think there isn't any specific test that we would ask. A lot of our colleagues do come back and say, I need to start my dental practice, my ENT practice, and I'm going to be very close to a patient. Should I, from time to time, do my RT-PCR? But unless there's any symptoms and if they're taking proper precautions, there aren't any tests that suggest they do.
Next question is to Dr. Ratnamani. Is there any possibility of kits made in India coming and the global acceptance in terms of reliability? Made in India coming and the global acceptance in terms of reliability?
Presently, I think some work is being done on the automated PCR method, which will act as a point of care testing, something like the one which the Abbott is there in the US. There is work going on that. And other than that, the one antigen test which has already come into the market from my labs. But beyond that, no, nothing else presently, except for the automated PCR, which will be total point of care testing, which is being looked at by some companies.
Sai, go ahead.
Sure. So there was a bunch of Patel zero prevalence study. We'll have to keep because questions were asked about why did the junior docs get it, what consultants got it, what was the reason for the ethnic differences? Can you kind of pass some of these topics and kind of suggest that? The other question with that was the UK SAR rate was pretty high, and what was the reason for that? If you want to kind of postulate on that for a minute or so, it would be great. The last speaker had given some very interesting topics on the newer tests. I'm sure this is a question I'm asking. Many of you saw the Emirates ad where they had dogs sniffing up the patient. Is that a real thing, doctor?
That's a good question, and I honestly don't know. I also saw some information on that, but from the NIH CDC documentation, I have not seen any of that. So, but as you know, sometimes some of those agencies can be behind. So I would always have begun to question. And this is actually an overarching phenomena that I have seen over the past 220 days that we have all learned from, is that many times even our most knowledgeable agencies such as ICMR, CDC, NIH, WHO, they are slow to react. We as clinicians on the ground need to be reacting, and we did the same thing with putting masking for our healthcare workers about 2 to 3 weeks before the recommendation came out, both from the CDC and WHO. So we will see what that comes out to. So I don't know the details on that.
Okay, thanks, Dr. Jain. I'm going to take
1 minute. I think there's a group from Israel who were testing along with Sir Gangaram Hospital. They were testing nasal-based test, which would be looking at volatile fatty acids and make the diagnosis in 1 minute's time.
Yeah, I mean, I think they've done this study and several hospitals. I think we await the data. That's quite exciting work. They've also been looking at nanoparticles and certain frequencies to pick up rapidly. It'll be very interesting. That data should be out soon.
Thanks, Anupam. Thanks, Dr. Rathan. One other question. Somebody had a question. Somebody has an antibody test that comes positive. Then they end up with symptoms and getting readmitted. Do you do a repeat RT-PCR on these patients? Ram, do you want to take that practical question?
Yeah, this is a little confusing in the sense these patients recover and then subsequently have another episode warranting hospitalization. Either they become breathless or have increasing fever. Now, there is no test which will help us at this time because the antibody, I suspect, will definitely be positive in most people if you do use the correct kit. And the antigen may be positive because, as we know, they cough up the dead antigen from the pulmonary tissue, and the antigen or the RT-PCR may be positive. So I think there is no way to definitively prove unless you do viral cultures, which is not commercially available as yet. So this will always be a mystery. There has been a recent French study where they looked at about, I think, 12 people who had reinfections and then tested positive, but I don't think we have definitive proof that the reinfection happens and we can identify without viral cultures.
I'll just add to that. This is Manoj. Very good point. I agree, Ram. And one of the ways that we've been having conversations of looking at this gene sequencing as well, and to see if it's the same virus or is this a new virus that has come in, and that will be very helpful. And in the newer tests, some of my lab people tell me that the next generation sequencing can be very helpful in that as well.
There is some evidence that in these patients, there's subgenomic RNA. It's not the virus, it is not the persistent of the virus, but subgenomic messenger RNA, which is associated with the membrane, and that's why it's more stable. But this can be detected. In South Korea, when they investigated, they found that there was no chance of recurrence.
Thanks, Dr. Rathan. Ram, one more question somebody had for you was the IgG to the spike or the nucleocapsid, which one's better? Can we even make out the difference? Somebody
yes, you can. The spike antibody to the spike protein is believed to have less cross-reactivity with other coronaviruses when compared to the nucleocapsid. So it is believed the spike is better technically.
See, definitely spike is the best because spike, the receptor binding site of the spike binds to the ACE2 receptor. So it's like the dagger. If you have antibodies to the dagger, you're protected. And there is in the disorin kit, you'll find that it is reflected onto neutralizing antibodies, and neutralizing antibodies will be protective. But of course, antibodies are a double-edged sword. So we should be careful.
Okay, thank you, Dr.
These antibodies have from diacerin also they detect against both the components of spike protein S1 and S2. So that is another big thing because it doesn't miss out. That's one thing, and they have been titrated against the plaque reduction assays as well. So there's a good study which has come from Italy on that. So I think that yes, as we progress in the pandemic, we'll see more and more role for neutralizing antibodies.
Great. Thanks, Dr. Raman. Clearly, there's a lot of interest and experts on this. We will have a whole separate webinar just on the spike antibody. So now, one question I had, I think I'm going to hand it over in a second, but one of the other questions I had was in terms of the testing strategy. So what we have heard, many of the questions have been answered in the chat box. Earlier on, there were a lot of detailed discussion on CBNAT, etc. Please look through that if you can. The other big thing was there are a lot of clinical questions. I'm not addressing those due to lack of time, including when do you use anti-IL6, when do you think of vaccine. We're not addressing that in this particular webinar, but these are very important questions. And if you can email GAPQ, I'm sure we can with more detailed answers. Sunita, thank you.
Yeah, there are a lot of very interesting questions here, and some of them not relevant to the topic as well, but a couple of questions, if any of you want to take this. In PIMS, the pediatric inflammatory syndrome, is there any additional role of CSF biomarkers or autoantibodies in the pediatric population? Is there a role of antibody titer in assessing pediatric prognosis? Ram or Sushmita, and if you want to take this. Role of biomarkers in pediatric population?
In the inflammatory syndrome, multi-system inflammatory syndrome is believed to be an immunological reaction. So I don't think there is a role for, at least intuitively speaking, there is no role for inflammatory markers in this, at least molecular markers in this. Whether inflammatory markers are of any benefit, I'm not sure. Unfortunately, I'm not a pediatrician, so I've not seen any case, but I pass.
Yeah, same here. I wouldn't be able to answer this question at all.
Actually, we've seen very limited cases. When I say we at the Apollo group, and I'm talking about Bombay, Chennai, Delhi, of this entity, and the biomarkers don't really have much of a role to play. I mean, that's what the consensus seems to be emerging here.
Sir, except for procalcitonin and CRP, they have been extensively used also serially. So definitely, obviously, PCD is pretty high, very, very high in such cases, as is expected. These two have been used in very limited experience. So especially as the child improves, what we are seeing is a definite fall and very drastic fall in CRP levels.
Slightly deviating from the topic that we are having, what about vaccines? When will they be available? Can we that we will have some vaccines that we can work with?
Well, I mean, I've just finished a seminar on vaccinology with the Chennai International Center a few hours ago, and I just did a review yesterday. So I think we will have in the next couple of months 2 vaccines in India. It seems like one Indian, one foreign. I don't know how much of it will be available. Nobody's obviously willing to give a definite date, but I think most of this will go to the government. Will go for, in all probability, armed forces and so on. I think early next year we're going to get a fair number, and by middle of next year I think we will be spoiled for choice. I mean, the capacity that we are talking about, Serum Institute is talking about 10 crore vaccines a month, and Bharat Biotech is talking about 5 crores a month. So we are looking at 160 crores in 12 months. Of course, Bharat Biotech will perhaps also export a bit, but largely for India, Serum Institute has to export 50%. So it'll be very interesting, but I think this space is going to be really alive in the next couple of months as the approvals come through.
That's great information, Anupam. Thank you.
That's great to hear. It's great to hear. So one quick thing that they had a question for the Nikhil. One of the questions was, is the RT-PCR and the CBNAT, can you re-summarize what the difference is? There were about 7-8 questions because I think they're all confused with the acronyms. So my understanding is these are all point-of-care tests. Nikhil, do you mind just quickly summarizing what the gist of your talk in terms of the terminology?
Let me help him then, if he's not there. CBNAT stands for cartridge-based nucleic acid amplifying test. This is the one that is used in CIFET, where you just have to put in the sample. It's a closed system, while the RT-PCR is an open system. So CBNAT will give you results faster, but the principle is RT-PCR.
Thanks, Dr. Ratan. That's helpful. Sunita, you want to add a comment on that?
So basically the same thing. In India, we use primarily TrueNAT. We don't have GeneXpert available readily in most places. Cepheid, I think, is primarily using it for the western parts of the world. The advantage with Cepheid's GeneXpert versus TrueNAT is that GeneXpert can be used as a point of care test, whereas TrueNAT still needs to be, you need to do some amount of RNA extraction, so it's lab-based test. So it's not a point of care test. But when you're talking about point of care from the US standpoint of view, you're talking about expert. When you're talking about point of care testing in India, you're talking about antigen. CBNAT is as good as PCR, whereas antigen sensitivity is low, but the specificity is good. So if you're doing an antigen and it is positive, you rest assured it is positive. You don't have to do anything further. If it is negative, then you have to do a confirmatory test by the PCR, either a TrueNAT or an RT-PCR, whichever is available in the setup at the moment.
Sai and Sunita, we will have to wind up. So I think I'm going to leave it to you to just wind this up now. Thanks.
Sai, take over and finish.
Just one more question to Sushmita. Sushmita, you know, the IL-6 level, people are all really hung up about what is the number. But what I recently saw was an article saying that even in regular ARDS, IL-6 shoots up much higher than what we see in corona. So really the treatment, can we always based on IL-6, or is there something else that you want to add on that point? And then we'll close out.
Yeah, so we do find a lot of patients come in, you know, they're not that unwell, but their IL-6 would be very high. 3 things we definitely do when the patient comes in, and we suspect they are early respiratory failure or at risk of being worsening ARDS. So we send ferritin, we send CRP and a procalcitonin. Lots of patients can, especially in our part of the world, do present with mixed bacterial infection, and there the IL-6 levels are high. Along with that, if the procal is high, there we would think twice about giving them any anti-IL-6 treatment. Therefore, for baseline IL-6 with a procalcitonin, ferritin, and a CRP is what we do. And then we monitor if the patient is worsening with hypoxia, if they're worsening with increased oxygen requirement, then we would, if they have baseline normal IL-6 values, we would repeat the IL-6. Along with that, we would repeat CRP as well.
Perfect. Thank you so much. So I think we'll close, Anupam, as you requested. So we've run through RT-PCR, CBNAT, it's from Nikhil. We talked about Ratna talking about the antigen test, the seroprevalence by Dr. Patel. We talked about serology with Ram, the newer tests with Dr. Jain, and we had a contribution from all the moderators. And I think we're still a great unknown, but we had really great input from every speaker. Thank you all. Thank you, Sunita, for hosting this with me. Anupam, over to you. Thank you.
Thank you so much, Sunita. Thank you, Sai. Big thank you to everyone who stayed connected. We did hit 554 just on a number of participants just on this platform. And this, of course, goes on to multiple platforms. So we'll know by tomorrow how many we had. But it's been wonderful interacting with everyone, great learning experience. Big thank you to our faculty, to all the speakers, to all the moderators. And it's time to say bye, and we will reconnect again. Thanks ever so much.